Thanks, Jack. So I need to start out with a disclaimer, apparently. I do not know everything about cracked teeth or pulp caps. So we thought we would finish up the scientific session, scientific presentations with just a mellow topic, something that's uncontentious, nobody cares about or has strong opinions about. And admittedly, this is probably a little bit of a goofy title, but on the other hand, as Jack alluded to, it's a question that we're really faced with, aren't we? I mean, we see patients with cracks in their teeth, we inform them, and this is the response a lot of times. And I think what makes this kind of a poignant question is the fact that, speaking for myself anyways, I'm not exactly sure what the correct answer is to this question. And so Joel talked about this earlier when we did the original surveys way back when we first started out on what your priorities were for studies. Cracked teeth was the top topic. Actually, cracked teeth was number one and tied for number two for the topics of most interest. And so I'm just going to review with you a little bit of the background behind cracked teeth and the study questions that we came up with. We'll talk about the methodology and how we ended up deciding to go about it. You may recall that we had a lot of animated discussions about cracked teeth and the best way of studying them and what we ended up settling on. And then obviously we'll try and spend most of our time in the results and discussion and see if there's any conclusions and leave some time for questions at the end. So, as we've discussed cracked teeth, we figured that most of the questions that we deal with fall into one of these three, or at least these major categories. What cracked teeth are likely to get worse? When do we need to intervene? And once we've decided when to intervene, what should the treatment of choice be? So those are the three questions that we have wrestled with and tried to figure out how can we go about answering that question. And as we've done before, we've asked some preliminary survey data before we started the study to try and develop some information that we could use for deciding on a methodology. And so we started out by asking how many patients come into your practice with cracked tooth symptoms, symptomatic cracked teeth. And by and large, people said that they had anywhere from a few to several teeth coming in every week with symptomatic cracked teeth. And then we followed that up and said, of those individuals that came in with symptomatic cracked teeth, how many of them would you say had another tooth that had a crack in it as well? And about 75% of you said a half or more of those patients also had another cracked tooth. So obviously something that had to be dealt with, an issue that is of importance. What do we already know about cracked teeth? Amazingly little. First of all, let's define what a crack is. And we had to, because cracks mean different things to different practitioners. So we're calling this a break or a disruption in the structure of the tooth without a separation of the parts. So in other words, we're not talking about that cusp that fractures off or breaks away. But most of the data that's been out there to date is our case studies. It's empirical data. There's not a whole lot. We'll have some estimates of incidence that vary widely, anywhere from 4/10 of a tooth that's cracked for every 100 teeth to 10 times that amount. And different studies have looked at incidence of how often the cracked teeth come into your office. Is 1 cracked tooth a week, 3 cracked teeth a week. What we do know with a little bit more certainty is that cracked teeth is the third most common cause of tooth loss after caries and periodontal disease. So it's a significant issue. So the way we ended up deciding to address this issue of cracked teeth, and you may remember that we had a kind of a working group of about 40 or 45 of you who we were kind of in constant contact with, who was giving us feedback and helping us to develop ideas and how we should go about it. And we decided to develop a registry to identify patients with cracked teeth and then follow them over time. And the aims of that registry were to try and identify the risk factors that would predict adverse outcomes in cracked teeth, both symptomatic and asymptomatic. And then secondarily, to evaluate the outcomes of the treatments. Once you decided that the treatment was needed to be done, we wanted to continue and follow those teeth and see what was the effect of the treatment that you accomplished on those cracked teeth. What seemed to be most successful? Because we know that there's a variety of different interventions for cracked teeth, and there's a lot of discussion about what's the best way to go. Most of it is restorative, and it could be indirect, non-bonded restorations. It could be a bonded intracoronal restoration. It could be full coverage, or it could be an indirect partial coverage restoration. There's a whole variety of different ways that people consider going about taking care of and addressing cracked teeth. So for the registry, we decided that we were going to limit this to adults. We wanted to do permanent teeth, and it was also going to be limited to posterior teeth. We figured those were the most likely teeth that were going to have cracks. We wanted them to be available for the 2-year follow-up period. Again, because of some enrollment issues, we ended up accepting a shorter follow-up period, and then may or may not exhibit symptoms, excluding obviously if they didn't have any posterior teeth or the posterior tooth wasn't an occlusion. Then we weren't going to allow them to come into it. Then our selection of asymptomatic cracked teeth was going to be randomized. And so we used the same randomization scheme that you're familiar with and we've used with a number of studies in PRECEDENT over the last several years, where we had a randomly selected patient, and then we also assigned you a randomly selected tooth at which you would start your evaluation for a cracked tooth. So if you were given Mrs. Jones tooth number 2, you started evaluating number 2 for a crack. If that didn't have a tooth, you proceeded to 3, and so on sequentially until you either identified a posterior tooth with a crack or decided the patient didn't have any eligible cracks that could be entered in. Now, we figured the randomization process wasn't going to get us enough symptomatic teeth. So in addition to the randomization process, we also took on all comers as far as symptomatic teeth. So if you had a patient that came into your office that you identified as having cracked tooth syndrome or was a symptomatic cracked tooth, then you could enroll that patient. If they were willing to participate, then certainly you could enroll them into the study as well. So we would make sure that we would have an adequate number of symptomatic cracked teeth that were in the study. This was our goal, 700 patients, and because of the feedback we received, this seemed to be such a common problem and the number of individuals with cracked teeth coming through your practice, we had hoped that we could get all of these patients enrolled. We'd have enough practices and enough patients, we could all get them enrolled in a couple of months and then follow them over a couple of years. And we'd have this big bolus of patients that we would kind of follow through. That ended up not being the case, but that was our initial intent. Our goal, based on analysis from the statisticians to try and determine statistical differences, we wanted to get about a 420 asymptomatic, 280 symptomatic teeth, cracked teeth, and this broke down this way. If we get 35 practices with about 20 patients each and then a 12-8 split between asymptomatic and symptomatic teeth. The diagnosis was obviously to observe a crack in the tooth with magnification, and so we made that a specification. If you're going to participate, that you use magnification. In this day and age, that's really not an issue. The other thing that we wanted to make a diagnostic requirement was that the crack had to block transilluminated light. There's, again, a lot of issue. There's a lot of contention around criteria for cracks, so we had to have something in common that everybody would use as a common criteria for entering an eligible tooth into the study, and this was it. So that had to be observed under magnification, and then it had to block transilluminated light. And then any other testing that you would normally do to ascertain cracks in teeth. Biting tests, tooth sleuth, biting on an object, applying temperature, and seeing what type of a symptomatic response you had to temperature changes and things like that. So we were going to evaluate the cracks at the patient level, at the tooth level, and at the crack level. So the patient characteristics we were looking at, obviously the age and gender, and then if there were any signs of bruxism with the patient, parafunctional habits, other habits especially that might impact, like nail biting, chewing ice, just a kind of a rudimentary report on what their occlusion was, and then obviously any symptoms that they were reporting to you as far as pain to biting, pain to temperature, or spontaneous pain. Then the tooth characteristics we were going to look at is the tooth number, then where the crack was located and the direction of the crack. If there were restorations, and we wanted to know what surfaces the restorations were on, what the restorative material was, if you could ascertain it or not, and whether the crack connected with the restoration or not. Then we asked you to do 3 different measures of the size of the restoration, just because these have been used in different studies, trying to see if there's any relationship between restoration size, cracks, progression of cracks, symptoms of cracked teeth. And so we asked you to look at the occlusal surface and give us an estimate of how much of what percentage of the occlusal surface was taken up by restoration, how much of the total surface area of the crown was taken up by restoration, and then radiographically, how much of the clinical crown, what percentage of that was restoration. And then any pain that you solicited in your testing that you did, look for isolated periopockets, particularly if they were associated with the crack or not, wear facets, and what the opposing occlusion was. Primary things we were looking at were some signs of crack progression. That could have been if the crack got longer, deeper, became more stained, became palpable by an explorer when it wasn't. A cusp broke off. Obviously, we were looking for any signs or symptoms of pain development in previously asymptomatic tooth. If they did become symptomatic, assessment of pulpal vitality, and then obviously the radiograph. Are there any abnormal signs in the radiograph that might be indicative of problems with the cracked tooth? And then record what your subsequent treatment was. Obviously, we're not here to dictate what you did. We just wanted you to tell us what you did and then document it. So if you did any of these things, then let us know, and then continue to follow these patients and assess for us the outcome of the treatment on the cracked tooth. And then continue to follow all of these teeth, whether they ended up being treated or not, for the entire duration of the study. And that's probably a good point to remind you that this study isn't over either. This is one of the ones that we're trying to collect data up right to the very end. And so for those of you that are entered into the study, if there's any way that you can get any of these patients back for a final check, it is most helpful. And so the data analysis that you're going to see, as we have mentioned on some of the other studies, this data is still somewhat preliminary, and we'll have final data a couple of months from now. The total follow-up period, obviously, we're hoping for 2 years. We're not going to get that in everybody. And then, similar to what we talked about in the pulp cap, we wanted to try and make this as smooth as possible in the normal operation of your practice, so that when the patient came back from a normal periodic checkup, hygiene check, or so on, that you would collect additional data at that time. And then once again, trying to get a concerted effort to get that final data collection to see how those teeth have progressed over the period of time. So some descriptive results. This is from baseline, the baseline information. This is based on a total of 634 patients, 34 sites that had an eligible cracked tooth. Of the randomly sampled population of teeth, the prevalence of patients that had at least one crack was 78%. It's a lot, isn't it? 78% of posterior teeth had at least one tooth with a crack in it. But this is similar to other data that has been reported in other studies. It's very high incidence of this. Of those randomly sampled teeth, about 11% of them were symptomatic. The rest were asymptomatic. Here are some of the characteristics. 56% of them were mandibular tooth, 67% extended onto the occlusal surface, 84% were vertical, 91% on teeth with a restoration, and 92% of the cracks connected with a restoration. 383 total asymptomatic teeth, 251 symptomatic teeth. Remember, this is just based on the random sample, so that's in a random population. 11% are symptomatic. Remember, we over-enrolled symptomatic teeth. So we ended up with about a 60-40 split of asymptomatic and symptomatic teeth. So 219 of the 251 self-reported the symptoms, and the vast majority reported that whatever solicited pain was applied was brief in nature. And here's the percentage breakdown for the pain. Most, as you might suspect, the pain was to biting and to cold, and then you can see lesser percentages for some of these other categories of pain. The one thing that was a little bit interesting was the pain on release of biting pressure. I don't know about you, but I was always told that kind of a classic symptom of cracked tooth was pain on release of pressure from biting. And anecdotally, that was just never my experience, and it turns out that that's what all of you found as well, is that pain on biting rather than release of biting was much more common. Some more data, 4% of the teeth had an isolated periopocket, but only about half of them were directly associated with the crack. A little over half had wear facets. Most of them were in the slight to moderate category. There weren't a lot of heavy occlusal factors on these teeth. Half were in occlusion with a natural tooth. Obviously, half were in a restored tooth, and then 54% had multiple cracks. And what this is telling us is how many surfaces, what percentage had multiple cracks. So in other words, 33% had one surface with multiple cracks. 37% had two surfaces with multiple cracks, and so on. So that's what that little table is telling us. So here we are into another depiction of odds ratio. So this is, you've seen this several times, and so I think you're probably familiar with it. As Joel and Joanna have explained, an odds ratio of 1 means that there is no difference for the factor that is being evaluated to whatever it is being compared to. If the odds ratio is above the line, then it means that this factor or activity is more likely to occur than what it's being compared to. If it's below the line, it's less likely. And the yellow bar is the lower bound, the blue bar is the upper bound of the 95% confidence interval. And so if that 95% confidence interval does not include the level 1, then it's statistically significant, and that's depicted with the asterisk and then the red box around the factor that's significant. If it's yellow like that, it's borderline significant. In other words, it does include 1, but just barely. So, whether there might be something there. So this first group of data, I'm gonna show you kind of 2 sets of data here. The first group is based upon the baseline data. So this is the association of tooth characteristics that are associated with pain or the symptomatic teeth. Okay, after I go through this, then we'll talk about the follow-up data based on crack progression on the teeth after the baseline period. So tooth characteristics, if there was a restoration present, it was 2.3 times more likely to have pain than if there was not a restoration present in the tooth. Makes sense. And if there was an isolated periopocket borderline, it was about 2.2 times more likely to have pain on that cracked tooth. Crack characteristics that were associated with reporting pain, if the crack was on the distal, facial, or the lingual surfaces, it was more likely to be associated with pain. If the crack was in the oblique direction, it was borderline significant. If there were multiple cracks on the tooth, then it was more likely to be painful. And for every surface above 1 that was involved in a crack, it was this much more times likely to be symptomatic. So, yeah. And then restoration characteristics. If the crack was on let me go back. If the restoration was on the distal surface, it was less likely to be associated with symptoms. If the restoration was on the occlusal surface, it was more likely to be associated with a symptomatic tooth. And if the restorations included the facial or lingual surfaces, it was more likely to be symptomatic. Okay, so occlusal, facial, lingual restorations, more likely. Distal surface restoration, less likely. And then restoration size associated with the reporting pain. Remember those various estimates of the size of the restoration that we asked you to do? Essentially what this is saying is that the larger restorations, as estimated by the surface area of the anatomic crown and the occlusal surface, the larger restorations were significantly more likely to have symptoms to be painful than teeth that had smaller restorations. That didn't hold up in the radiographic crown category, but in these other 2 categories, it did. So that's the end of the first group of data that I'm going to present to you. So this is the baseline data and the association of the various characteristics to symptoms and to pain. Now we're going into the follow-up data of the patients that were seen for at least a year of follow-up. So out of that initial bolus of 634 patients that we were just talking about, 373 of them had more than a year of follow-up. And there were also 5 teeth that ended up being extracted after the baseline visit. So we're talking about a total sample population of 378 subjects that we have follow-up data on as of this data pull and when the analysis was done. So the mean follow-up time was a year and a half. So basically what we're talking about is on this crack progression data was over an average time period of a year and a half. And so in the primary outcomes that we were looking at, from baseline until an average of a year and a half later, a little over 2% were extracted or had root canal therapy, and as you might suspect, most of the treatment was restorative. This is something that I wanted to highlight for you because I found this kind of interesting. I mean, we think of crack progression as being something that takes a long time, and in a lot of ways it does. I mean, it takes years, decades for some of these things to evolve. So I was a little bit interested to see that nearly 10% of the initially asymptomatic teeth had developed symptoms in just an average of a year and a half. And here's another interesting thing. Of those that developed symptoms, the vast majority of them developed the pain symptoms before you did any treatment. Only 3 developed after first treatment. So whatever treatment you did, regardless, this isn't broken down by treatment type, but whatever treatment you did was effective at preventing crack progression in terms of developing symptoms. Again, this is just a summary of the same data that was on the previous slide, so you had it available to refer to. 25% showed other signs of crack progression. So in addition to the symptom development, the things that you assess, like did the crack become longer or deeper, or did it stain more or involve more surfaces, or were there more numbers of cracks, did periopockets develop? 25% of the teeth showed this type of progression, again, in just a mean period of a year and a half. And once again, most of this crack progression occurred before you did any treatment. 33% progressed before treatment, less than 8% progressed after treatment. So once again, the treatment that you applied to the cracked tooth, regardless of what the treatment was, most cases restorative, was effective at preventing the development of symptoms and other signs and progression of those cracked teeth. Some descriptive follow-up, a little over half were female, 61% exhibited signs of bruxism, 44% were maxillary teeth, 90% had a restoration present, just shy of 60% had a wear facet, most of which were, none to slight, a little bit moderate, very few that were in the severe category. The crack location, this is just depicting where you found the cracks. The crack location was very evenly divided between symptomatic and asymptomatic teeth, except for the facial and lingual surfaces. There tended to be a higher proportion of teeth that had facial cracks that showed progression in the symptomatic category, and same for the lingual, higher proportion that showed crack progression that were in the symptomatic category. Crack direction, vast majority were vertical, and oblique a little bit less than, or significantly less than that, and horizontal a little bit less than the percentage of oblique. So now we're looking at patient characteristics associated with crack progression. So this is the follow-up data, and these are split. You'll see this over the next several slides where we have split out the asymptomatic teeth compared to the symptomatic teeth. And I'll make it very simple for you. You can just kind of focus on the left side because there were no significant differences, significant correlations or increased or decreased odds of crack progression in symptomatic teeth in any of the characteristics that we evaluated. In the patient characteristics in terms of age, gender, bruxism, no differences in the asymptomatic teeth either. When we look at tooth characteristics that were associated with crack progression, maxillary teeth were 2.3 times more likely to show crack progression than mandibular teeth, and teeth in which the crack connected with the restoration were significantly less likely to show crack progression. I'm not sure, does that mean the restoration blunted the crack? Does it mean that the restoration hid the crack and we couldn't observe the progression of crack? I don't know. But those were the two significant findings from the tooth characteristics. As far as the crack characteristics, if the restoration was on the distal surface, it was less likely to show crack progression compared to cracks on other surfaces. And if the crack was in the oblique direction, it was significantly more likely to show crack progression than teeth without oblique cracks. In other words, cracks that had vertical or horizontal cracks. As far as restoration size, you recall when we talked about the symptoms that we did see some increased odds for symptoms with larger restorations. Did not see that same association with crack progression over a year and a half. There was no significant association, increased odds or decreased odds of crack progression depending on the size of the restoration. So if we consider, and try and pull some things out of here, the odds ratio for symptoms now, so this is the baseline data. The odds ratio for symptoms were elevated if a restoration was present and there was an isolated periodontal pocket, if the crack was on the distal, facial, lingual surfaces, or it was oblique in direction, if there were multiple cracks in multiple surfaces, in other words, more extensive crack system in the tooth, tended to be more likely to have symptoms. The restoration characteristics, the type of restoration ended up not being significantly related to symptoms. Facial, lingual, and occlusal surfaces were associated with an elevated odds for cracked teeth, but a lower odds ratio on the distal. And it's harder to see as we've kind of tried to bang this around and take some lessons or clinical significance out of that. Thought, is it just perhaps because the distal surface is harder to observe? It's just harder to see the cracks, harder to follow the cracks and characterizing them and see how they do. And then restoration size, the larger restorations that occupy more surface area of the tooth or the occlusal surface are more likely to be symptomatic. As far as crack progression, so this is the follow-up data we're talking about, the signs of crack progression. Again, this is limited to asymptomatic teeth because none of these showed any significant factors in symptomatic teeth. If the crack connected with a restoration or the crack was on the distal, it was less likely to show crack progression. Conversely, it was more likely to show crack progression if it was a maxillary tooth, it was oblique in direction. Restoration characteristics, again, weren't significant. Size wasn't related to it. I would think, a couple of the interesting takeaway messages, first of all, is that I would think, and this is subjectively saying this, but in a mean period of a year and a half, I think it's interesting to note that nearly 10% of the asymptomatic teeth became symptomatic, and a quarter of the teeth showed some other signs of crack progression. The other thing is that treatment was effective. Most symptom development, crack progression, occurred prior to your first treatment. So whatever treatment you applied was effective at reducing crack progression. Some lessons learned from this study, I think, and Joel was alluding to this earlier, is the keep it simple principle. And I think from the feedback we got, one of the issues with the cracked tooth is we were trying to collect too much data, and it became too involved to record all of this. And even though we tried to include you as we were developing the questionnaire, obviously anybody who's doing research, you want the most data you can get. You want more information. But trying to incorporate that into the flow of your practice, I think maybe we overdid it, and maybe some lesser, simpler measures would be better. And then time. I mean, this is a study that would obviously benefit from longer recall periods. When you're following cracked teeth, in order to take some lessons out of these, because some of these are hard for me to decipher as to what the clinical significance of it is. And so it would be wonderful if we had more time that we could have followed these cracked teeth for. So I'll leave you with a few conclusions. Symptoms in teeth with cracks associated with certain characteristics: multiple cracks, multiple surfaces, more extensive crack systems in the teeth, and then presence of restorations, regardless of the type, and crack progression in asymptomatic teeth associated with maxillary teeth, oblique crack direction. And again, follow-up is critical for this study, and we've got a little bit of time left where we can get some of these patients back in for final data points. And so if you could provide us with that, that would be wonderful. And once again, our thanks to NIDCR for funding this, all of you and your wonderful staffs for providing us with the study and the information. So let's open it up for any discussion or questions or comments or thoughts. And feel free to comment not just on the, on the data, but if you were a participant in the study and you have any thoughts on how the study went and how it could have been improved, then be sure and pass that along to us as well.
Yeah, you stated that the restorations that were done by the dentist seemed to have helped. What percentage were crowns and what percentage were like composite restorations?
Yeah, and I don't know, Yates, do we know that yet? No. Yeah, we don't have that level of detail at this point. I mean, we will. I mean, we've got the information. You provided the information for us, but we don't, we don't have that right now. Yeah.
So I was part of this study, and one of the data points I had trouble with in the recall was, has the crack progressed, because there was no real measurement of the crack. And I started taking pictures on my own after a few studies, but that would have been nice to have some kind of quantitative measurement.
And I agree with you 100%. And we toyed with both asking for folks to take photos so we could assess the crack progression over time, or the other thought we came up with was doing a diagram, where you drew it on there and maybe did some rudimentary measures. But again, we were afraid that was taking us even farther away from trying to keep it simple, and it would be more complex and more time consuming. And so while I agree with you, that would have been better information, we were afraid that was just going to make it even more time consuming and complex.
Well, I just felt like the validity of my answer to that question on some of those was a guess.
Yeah, understand. Yeah, some of those are going to be more objective than others. The longer and deeper certainly are going to be more, it's going to be hard from one to the other. But fortunately, things like, whether it connected with the restoration or not, number of surfaces that are involved, multiple cracks, that should be a little bit more objective data that you can hang your hat on from one time period to the next.
Other questions? God, you guys were all hot to trot about this 7 years ago.
Thank you very much for this presentation. I don't want to press fundamental studies very much, but again, this is an example where new approaches in curing cracks, first of all, observing cracks where they are, their characteristics, structural characteristics, and then curing them via new approaches, rather than just filling them in with foreign materials, foreign to biology, which we know is eventually going to fail, I think would be a good way to counteract the problems. Do you have any insights on how you actually could follow up on the studies, these beautiful studies that we have been listening, so that we can go to the next step of having much less number of these patients in the offices?
Right. Yeah, and I think your point is well taken in that I think, we need to do some combined studies, and Jack and I have been proposing some where we can do some basic science evaluation where we take cracked teeth and evaluate them in the laboratory and characterize them, you know, the way we would clinically, try and characterize the external cracks, but then use some of these advanced techniques and methodologies, ultrasound, microcomputerized tomography, and things like that to determine what is the actual 3D pattern of the crack. And then let's put them through some artificial aging and stressing and see how do these cracks actually move and progress, and which characteristics that we can assess externally actually are meaningful, which ones are more ominous than others, which ones are more likely to progress. And so I agree with you completely. I mean, I think a combined basic science and clinical approach is exactly what's called for in going further in this area. You bet. Yeah.
I noticed, I was in the study and noticed in my practice not keeping strict control, and this isn't just study patients, but far and away the predominant of fractured cusps, and even when I saw them, cracks, let's say there was were not on the stamp cusp, but on the opposing
The
cusp.
non-functional cusp?
Right, where it, might have been, less from a compressive force, but more from a
Oblique forces?
an oblique force on it. Any data on that from any studies or something that would show?
Yeah, there was another practice-based research study that was done that looked at cracked teeth, specifically at cracked molars, and found a significant association of wear facets to cracked teeth. And so that might be indicative of exactly the type of movement you're talking about, where you have a wear facet out on a cusp that's more indicative of a parafunctional movement or a non-working interference or something along those lines. So yeah, that, there is some study, some research that has shown that association. We didn't find it in this, but there are other studies that have.
Tom, as far as the teeth that were extracted, do you have the crack characteristics that existed on those teeth prior to their extraction? The reason I'm asking that is that it seems to me, anecdotally, that teeth that have large restorations tend to fracture off either facially or lingually, and I can restore those. But those teeth that have no restorations that crack are usually catastrophic and they're unrestorable.
Yeah, I mean, we should have that data, but we haven't looked at it. And the problem is numbers. Like I said, we only had 5 extracted teeth, and so I'm not sure if we're going to have enough data to draw any statistical conclusions from it. But we can certainly go back and look at that and at least make some observations of see if there are any commonalities among them. Yeah, I agree with you. Yes.
As I remember, much of the fighting when we first talked about this was what to do with the teeth. And in this, it just says whatever you did apparently worked. But
right.
my question, I mean, a lot of what people, again, as I remember, we're talking about is, can we just put a bonded filling in this as opposed to
right.
crowning the tooth? So any numbers with what people did to the outcomes with this?
Right. Yeah, and I remember those discussions well because we were talking about the ideal way of doing that is people need to be able to be willing to randomize their patients in, they have got a cracked tooth, and regardless of how you normally treat it, you had to be willing to randomize it into, like a bonded restoration as opposed to a crown, and that's what caused a lot of the. Yeah. Right. Right, exactly. And so, yeah, I mean, we've got the information on that, on what the treatments were that were done. Do you remember to what, I mean, it was type of restoration, right, and restorative material that was done. We have that. But we just haven't had a chance, to analyze that. We just haven't had a chance to do it yet, because that's more of the follow-up data. Did you have some? Yeah. This is Yates Cole. Yates is the lead statistician on this study, and so she keeps me straight.
That's a case where we need more follow-up data, particularly on patients who've had treatments. So we've already started looking at that, but we weren't able to make any conclusions. We weren't able to see any sort of statistically significant differences based on treatment for any cracks that got worse after treatment or any symptoms that developed after treatment. So please finish follow-up.
Yeah, more follow-up, more data, longer time.
Okay, we'll do one more.
So when you say follow-up, I thought I was practically done with everything.
You what?
I thought I was practically done with, like, 2-year follow-up was done.
Yeah.
And when you say more follow-up, do you want me to do more of those as the patients come in?
If you've done the final recall, if you've done the 2-year recall, then no. But if you have any patients that haven't had the final 2-year recall, then absolutely, that would be wonderful for us to be able to get that data on. You bet. Okay. Well, as the final speaker, I'm going to use the speaker's prerogative to take a couple of minutes. I don't know if there is such a thing, but I guess if I don't yield the podium, there is. But I wanted to kind of revisit some thoughts that I developed, a number of us developed 7 years ago when we started Northwest Precedent. And we were going out and we were starting to recruit folks to come in and pose this question: should I participate? As in, should I participate in practice-based research? And I'd like to kind of review some of these thoughts by starting out by showing you just a short video clip. And you may recognize it because it was a commercial in a Super Bowl ad the year before Northwest Precedent was launched.
I won't tell if you won't.
I love that video. I love that video. Not because of the product that it's trying to sell, but because of the sentiments that it expressed. Because, you know, I know that sometimes I've been that pony. You know, I thought I was the one that was out front, hauling, leading the way. But in reality, there were people behind me, teachers, mentors, important people in my life who were really doing the heavy lifting and pushing to move things forward. And, you know, we're in a similar situation, I think, if we're honest, in dentistry, where a lot of times we're out in front of this wonderful profession because of those researchers who have preceded us, that have gone out and done the heavy work and the lifting, that have provided us with the information and the techniques and the materials that allow us to practice dentistry at the high level that we do. You know, I believe for a number of years that as dental professionals, we have an obligation to not just be consumers of dental knowledge, but to be producers of dental knowledge as well. Because what goes around comes around. And the thing is, when that challenge came around to all of you, you accepted it. You said, I'm going to be part of this. I'm going to be a producer of dental knowledge, and I'm going to be somebody that's going to help to move the profession forward by doing that hard work and gaining the information. And I hope that you continue to answer that question in the affirmative, that you will continue to be a part of Northwest Precedent. And I just want to say that I want you to know I couldn't step aside from Northwest Precedent without letting you know what a privilege it's been for me, and not just me. I know there are others that could say this better than I am, but I'm sure everyone feels the same sentiments. What a privilege it's been for us to get to know you and work with you over the last 7 years. And so I'd kind of like to reverse the normal custom right now. I'm going to ask the Northwest Precedent staff, and Don and Dina, I'll invite you, and Greg and Jeff, let's us stand and show our appreciation for our practitioners and our friends and their staffs. Thank you. It's been a pleasure and a privilege, and I hope we get to continue our association in the future.